Hi, my name is Bree Watson, and I am the marketing manager at Warwick Forest. Warwick Forest is the premier sponsor of the Lifelong Learning Society, and we welcome you to the Riverside Lecture Series. Today, I have the pleasure of introducing Dr. John Lamm. Dr. Lamm earned his medical degree in 2013 from the Brody School of Medicine at East Carolina University. He completed the neurosurgery residency and the fellowship in functional neurosurgery at the University of Kentucky in 2018. Dr. Lamm is eligible for certification by the American Board of Neurological Surgery. Fascinated by the quickly advancing field of neuroscience, Dr. Lamm enjoys the opportunity to apply newfound discoveries to the real-life situations and change people's lives for the better. He approaches his medical practice with the golden rule: caring for patients the way he would want his physician to care for him. Dr. Lamm believes that this starts with tailoring individualized care to every patient he has the privilege to treat. Dr. Lamm possesses expertise in the surgical treatment of the brain, spine, and peripheral nerve disease. In addition to general neurosurgery, he has specialized training in brain and spine trauma, peripheral nerve surgery, and gamma knife radiosurgery. Originally from Greenville, North Carolina, Dr. Lamm enjoys Hampton Roads for the surrounding water, great seafood, and close proximity to his extended family. Outside of work, he can be found sailing, woodworking, or gardening. Dr. Lamm and his wife have 3 children. Please give him a warm welcome, Dr. John Lamm.
I'm Dr. John Lamm. I'm one of the brain and spine surgeons working at Riverside down the street. And I have a practice here at Newport News. I've also run a clinic out of Williamsburg to see folks from the extended area. I believe my partner, Dr. Salvant, was originally slated to speak with you today, but he asked me to fill in at the last moment, and I'm excited to be here. The treatment of movement disorders with brain surgery is one of my big focuses of interest. I spent additional time during my training doing some research in the area, and we are really excited to be offering one of the newer, latest and greatest treatments, the MRI-focused ultrasound here at Newport News. And we'll also be talking a little bit about the deep brain stimulation that's been around for, almost half a century now. We're also excited to be the only facility on the peninsula that offers that treatment. So the root cause of the tremors that we see with essential tremor and with Parkinson's disease, the movement disorders, is due to kind of a helter-skelter, the neuroaxis being thrown off by generally a lack of dopamine production in Parkinson's disease. And that's from the substantia nigra, denoted on the center of the diagrams there, the SNC. This is a kind of an artist's rendition of the very center of the brain, the midbrain, and diencephalon, the deepest part of the brain. Shows the axis of the substantia nigra. Communicating with the globus pallidus, which is on the right side of the 2 diagrams, showing the indirect and direct pathways through the external and internal parts of the globus pallidus, denoted by the kind of yellow, purple, and I suppose light pink areas, the triangular part there. That communicates with the thalamus, which is the main hub in the center of the brain that controls some of the sensation and movement pathways. And usually things travel in a loop, both to accelerate movements and to decelerate movements. When those axes are thrown off kilter, we start to see either too much movement or too little movement, resulting either in a tremor or with slowed movement or stiffness that we see in Parkinson's disease. This is a very complex pathway. We like to think that we understand it very well, but every time we discover something new, we realize how little we do actually. Parkinson's disease, one of the main diseases that we treat with surgery for movement disorders. It's most commonly onset around 60 years of age. Often we see it with a later onset, especially in more mild cases. Occasionally familial cases will show onset as early as the 40s or 50s. That's usually due to a genetic disorder that seems to run in some families. It is classically associated with a resting tremor. We often call it a pill rolling tremor. It's also associated with rigidity, causing some slowness and bradykinesia, and a loss of balance. Sometimes this is due to the slow movements or incoordinated movements, and also that can be due to the progressive postural changes that go along with Parkinson's disease. Stooped posture is a very common look to folks that have a more advanced condition. It's a progressive disease, despite all of the great treatments that we have to offer with medicine and the surgeries that we'll be talking about today. It's unfortunately not something that we can stop in its tracks, and our treatments are more focused on treating the symptoms and improving the lifestyle of folks that suffer from the disease. Dementia is a common symptom that goes along with this in the more advanced stages, and depression is also associated with the disease, sometimes due to the dementia and sometimes due to the life-altering changes that go along with the other motor symptoms. About 1 million people are thought to be affected by this disease currently in the United States, and then we expect about a 20% increase with the increases in the population and the fact that people are leading longer and healthier lives. We expect to see an increase to 1.2 million in the next 10 years or so. And so that translates to about 5 to 35 out of 100,000 folks being diagnosed with these symptoms annually. The root cause of this, kind of like we saw in that complex diagram at the beginning of the talk, it's caused by a loss of dopamine secreting neurons in the basal ganglia regions of the brain. And so the dopamine is an exciting neurochemical that gets transmitted along the neurons and in between the neurons in the brain, and helps regulate our movements. As we mentioned before, it can be hereditary in some instances, often causing a very early onset and leading to some of our more advanced and severe cases. The underlying cause is generally unknown. We know the neurochemical pathways that are affected, but exactly what causes this is still a mystery, other than the few folks with a genetic disorder. Historically, it was associated with encephalitis in the 1918 flu pandemic. We've also noted some Parkinsonian-like cases in people with chronic traumatic encephalopathy. I think most famously, Muhammad Ali had a Parkinsonian-like syndrome. And we see it with some of these folks that get a lot of concussions in some of the contact sports today. In the early 1990s, we also associated it with the synthetic drug, the MDMA, some people call it ecstasy, where there was an overload to those dopamine secreting and receiving neurons, where we also saw folks with Parkinson's disease essentially in their 20s. Essential tremor affects people in a similar way to Parkinson's disease. However, it's almost exclusively a motor issue. It involves a rhythmic shaking, sometimes at rest, but we can differentiate this a little bit from Parkinson's disease in that it bothers people quite a bit more with actions. They're trying to take a drink or reach for something or use a pencil. This is much more often hereditary. About half of our cases, we can pinpoint it to an aunt or an uncle or often a parent that had a similar symptoms. Many brothers and sisters suffer from the disease. It affects most commonly people's arms, and that's generally the ones that people notice the most and lifestyles are affected by the most. But we also see it affecting people's head, as well as their voice. A lot of people have a tremulous voice when they suffer from an essential tremor. About 10 million people seem to be affected to the point where they seek medical care for this disease in the United States. As far as treatments that we have to offer, the first line treatments we seek are medical treatments. We usually keep surgery as a last line option. For Parkinson's disease, a lot of times this involves replacement of the dopamine, which is no longer secreted at adequate levels in the brain. The most common medication we prescribe for this is actually a dopamine replacement, levodopa and carbidopa. So the levodopa refers to the molecular structure of the dopamine that we can replace, and then the carbidopa keeps the medication from being absorbed too much in the gut, so it actually makes it to the brain. So those are offered in combination as a brand name medication, Cinemet. The other medications listed there, the Mirapex and Xadago, are also available, and Nupro is one that we can often offer in a patch with people that have side effects from oral medications. There's also some pumps of medications which we can inject into this either the spinal canal or in the subcutaneous tissue, similar to an insulin pump for someone with diabetes. When these medications are no longer effective, we start to consider things that involve surgery. One of our tried and true methods of surgery is the deep brain stimulation, which we'll be going into detail a little bit more here in a moment. And then things that predated the deep brain stimulation included lesioning procedures, either with heat and electricity deep in the brain or with radiation. Those ones were largely abandoned in favor of the deep brain stimulation as early as the 1970s. A lot of times because the results were often delayed and irreversible, and our targeting and geometric understanding of the brain was not as advanced as it is now. And more recently, in the past decade or so, the MRI-focused ultrasound has brought lesioning procedures back into vogue with our advanced technology. And that's one of the things that we're really excited about starting to offer now. The treatment for essential tremor is a little bit different. Rather than it being a issue with the dopamine axis of the brain, we're able to treat this with medications that seem to calm the nerves and calm the body. And so that includes things like beta blockers, which are often used to calm the blood vessels to help with increased blood pressure or with fast heart rates. These beta blockers seem to help with essential tremor as well. There's another medication that affects the nerves called primidone. And then deep brain stimulation also is used to treat that, as well as the lesioning procedures that we mentioned before and the MRI-focused ultrasounds. Often with essential tremor treatments, since we're talking about slowing things down, we also often find that anti-anxiety medications, ones that are commonly used like Valium and Xanax, that help calm people's minds also seem to help with calming a tremor. And then I suppose I shouldn't endorse this as a physician, but we often hear that our folks that take a drink or two have a considerable improvement in their tremor when they have a glass of wine or beer in the evening. With our deep brain stimulation, this involves a real surgery, a real brain surgery, where electrodes, wires are implanted into specific regions of the brain. So there's specific targets that we use for Parkinson's disease and essential tremor deep in the brain to affect those pathways that we brought up on the first slide. We like to think of this almost as a pacemaker for the brain. And so it's a two-part surgery that involves implantation of a battery that we generally store in the chest wall underneath the skin, just like we do with a pacemaker generator. And that's connected to wires that we run up behind the ear and then down deep into the brain. So the electrodes can detect the brain activity for allowing improved symptom control, and we can also use them to deliver electrical currents at very low levels and in different directions depending on the system that we're using to help with people's symptoms. So it's a nice treatment, and then it's adjustable. Once it's in, we can change the settings on the battery as needed to affect people's symptoms. It can be applied to both sides of the brain during the treatment for Parkinson's disease or essential tremor. It also is used to treat other diseases like obsessive compulsive disorder, sometimes with overeating disorders, depression as well, and are some of the areas that are being researched for this type of treatment. Since it is surgery, it does involve hospitalization at least overnight, and it does require anesthesia, which can be an issue for some of our sicker patients. This is a diagram from the Cleveland Clinic that shows what we're talking about here. On the top of the patient's head, you'll notice two wires that are going deep inside the brain, and they're connected to a little bit thicker blue wire that goes behind the patient's ear, down over their collarbone, and connects to a very small battery that's left on the left side of the chest there. I believe we have a video here.
It looks like a scene from a sci-fi movie, the medical science of the future. But it's happening right now in one of the new high-technology-based operating rooms at Riverside Regional Medical Center.
My name is Tom Larson. I'm 58 years old. I noticed my tremor about 7 years ago. I've gone through all the medicines. It did nothing for the shake. So now I'm at the point of brain surgery. Heard a lot of good things about it, and hopefully it's going to be the answer to my dreams here. Put me back in touch with the real world.
Tom has a tremor, an uncontrollable shake in his hand caused by a neurological disorder. He's researched the options, he's studied the procedures, and he's ready for one of the most advanced surgeries modern medical science offers, deep brain stimulation surgery, or DBS.
The technique that we use for the surgery is referred to as stereotaxis, mathematical calculations and geometry to reach targets inside of the brain. We used a combination of MRI scan and CT scan, as well as a sophisticated computer program and graphics station.
Dr. Jackson Salvin, a neurosurgeon with Riverside Medical Group, and his team of experts make the final preparations on an array of 3D computer imaging equipment and high-tech X-ray-like sensors used in this procedure. These computer sensors will guide Dr. Salvin to the area in the brain responsible for the unwanted tremor symptoms. A millimeter can be the difference between success and failure.
My hopes are tremendous. Get back my life, learn to write again, learn to be out with people, learn to relax. I can't relax. Everything is so stiff, so tight. Because you're trying to prevent from shaking so much. We did research on Riverside and I feel I'm in great hands. I'm getting the top-notch guy in this field and really look forward to doing this.
In fact, Riverside Comprehensive Neurosciences has the only facility on the Virginia Peninsula that offers this unique and advanced treatment option.
It's very important that we select the patients carefully. It's always in the patient's best interest to begin consulting with their neurologist before they consider surgery.
When the electrodes are in the target area, a small electrical charge is generated to alleviate the symptoms without causing unwanted side effects. Once a stimulating lead is precisely placed, it is later connected to an implanted pulse generator, similar to a pacemaker. The device then transmits painless electrical pulses to interrupt signals from the brain that cause the tremors. The entire surgery takes about 2.5 hours, and the results are immediate. Tom was back at home the next day.
Before surgery, he couldn't perform his signature. After the operation, we could see a very nice fluid signature. We saw a definite improvement in his tremor. All of the indications during the surgical procedure were that it was going to be a success in the long term.
Thanks to this cutting-edge technology, Tom's life is back to normal.
Big difference is no shakes. Been able to write, been able to communicate better, confidence level up. I had a great experience with the hospital. Riverside was super. I just want to thank them for giving me a chance to get my life back.
I guess a lot to cover from that video there. As far as the procedure for the deep brain stimulation, we usually do it in two parts. One is for the most exciting part, where we're implanting the wires in the brain. And so we generally do that part of the procedure first. It involves an overnight stay in the hospital. And I know it sounds a little bit crazy, but this brain surgery is actually done with the patient awake. Prior to the procedure, patients have generally undergone a CAT scan and an MRI, so we can take a good look at the deep brain structures and do a lot of planning with our calculations based on the geometry of the brain, like Dr. Salvin mentioned in the video. And we'll come up with a target deep inside the brain. Since we are implanting a wire in the brain, our trajectory for the wire is also important. So we plan the insertion site on the skull very carefully to avoid any other structures that we wouldn't want to damage. Once the patient arrives in the hospital the day of surgery, we have them come back to the operating room fully awake, and we'll have them relax on our table. And we will usually numb the scalp with some medication. We make 2 very small incisions. And we are able to develop a GPS system essentially for the brain by securing a small device to the head. And that allows us to know exactly where we are and where we're headed down to fractions of a millimeter within the brain. And that complex setup you see in there is actually an intraoperative CAT scanner that allows us to check our work as we're advancing the wires into their final position. One of the great benefits of the deep brain stimulation surgery, especially with our patients being awake, is that we can test our work while we're in the operating room. And so we'll actually deliver small amounts of test charges through a temporary battery, and we can quell the patient's symptoms in the operating room, make sure that everything we've done is just perfect before we're finished. Once we're finished, we'll tuck the open wires right underneath the scalp. We'll put a few stitches in the head to get everything all nice and closed up, and we have people spend 1 night with us in the hospital. And people generally go home the next day. To be honest, it's probably more of a precaution than anything else to have people spend the night with. I know it sounds crazy for people to have surgery on their brain while they're awake, but oddly enough, the inside of the brain does not have any pain receptors. So other than the small incision on the skull and the noise from making a small hole in the skull, people don't feel anything as the wires are inserted. So it's just really amazing that we're able to do this. Once people are recovered after a few days, generally about a week or so, we'll have people come back for the permanent implantation of the wire extensions to track the wire from the back of the head down to the chest. And we can insert the small battery underneath the skin of the chest, much like the pacemaker. That part of the surgery, since we don't need to do any additional testing, is done with the patient asleep. So that way it's not uncomfortable. and people get to go home the same day and start benefiting from the deep brain stimulation surgery. As people progress after the surgery, if the Parkinson's disease is noted to worsen at all, we can make adjustments to the settings on the battery and adjust the programming of the battery to affect their symptoms in different ways if their symptoms are to change over time. So it's a very great treatment we're excited to offer. The alternative to these deep brain stimulation surgeries are the lesioning procedures, which actually predated the deep brain stimulation. So historically, these lesions were created with heat or cold, delivered in a similar way through a wire, which was either chilled or heated at the tip to cause a lesion in a similar spot where we're treating with deep brain stimulation wires. This did require a surgical incision, much like the deep brain stimulation involves a small incision. It was also done with the patients awake, typically. As you might imagine, a hot wire is quite uncomfortable, or a cold wire also uncomfortable. This was mostly abandoned once deep brain stimulation became available. The alternative to this was also the radiosurgery, which we still use for other things such as tumors and pain inside the brain. That was less invasive, but also less testable, since the effects of the radiation are usually onset 6 or 8 weeks afterward. So the procedure would be performed. We'd keep our fingers crossed for 6 or 8 weeks, and then people would come back and tell us how things turned out. Obviously, with better options available, we've abandoned that in the last 50 years. The MRI-focused ultrasound has been clinically available as a treatment in the United States since 2016. It is a non-invasive alternative to the deep brain stimulation, which makes it very attractive as a treatment to a lot of our patients. It's an outpatient procedure, which just requires 1 visit, unlike the 2 visits for deep brain stimulation. Doesn't require any overnight stay like the first stage of the deep brain stimulation. This can be used to treat the essential tremor or tremor predominant Parkinson's disease. The big downside to this treatment is that we can only treat one side at a time. And that's mainly because we haven't studied treating 2 sides at a time. Not that it necessarily isn't safe, but we like to study these things under very controlled circumstances for a good amount of time before we start offering them to people without knowing exactly how things are going to go. But that's something that's certainly in progress, and we're hoping to be able to offer that treatment on both sides in the near future. And I guess when I say near future, I say the next few years. Yes, ma'am? Well, bradykinesia. Bradykinesia is a fancy medical term for slowed movement. So brady meaning slow, and kinesia meaning the movement. And that's a good point here. That is the other big downside to this treatment when we're talking about Parkinson's disease. It's extremely effective in treating the tremor. However, the other several symptoms that often go along with Parkinson's disease seem a little bit less well treated with this procedure. Where the deep brain stimulation can help quite a bit with bradykinesia and rigidity and sometimes balance, this particular treatment, the MRI-focused ultrasound, seems to be a lot more effective in just treating the tremor. This is a photograph of the setup for the MRI-focused ultrasound. So it does involve sitting for an MRI. It's much like a normal MRI, whereas instead of wearing a small mask where we keep people's head a little bit still so we can take a good picture, the ultrasound is delivered through what looks like a small dome that's fit over the patient's head. The ultrasound waves are delivered through water, which we are holding in place with what looks like an upside down shower cap. The water is chilled to avoid any excess heat buildup on the scalp. And the water is a better transmitter of ultrasound. Just like when we see ultrasounds taken of children, I think that's probably the most common way that people are used to seeing those. The ultrasounds are transmitted very well through soft tissue or the amniotic fluid surrounding a baby. The ultrasound is delivered through 1,024 different sonication devices, all contained within that dome. Small adjustments are made based off of the patient's skull thickness and how homogeneous or how similar the skull is throughout its density. It comes from multiple different directions and converges on a single point where we would like to increase the heat. And that way excess heat is not delivered to the other normal parts of the brain that we do not want to affect with our treatments. Our targets are typically deep within the brain. This one shows the thalamus here. And so in the very center of the brain, we have several fluid-filled spaces called the ventricles, denoted by the white. whereas the brain matter itself is colored in gray there on our MRI. And just off to the right side of center, you notice the convergence of all the green lines as the artist's rendition of the trajectories of the ultrasound waves converging on that small point to control the tremor. Our targeting is very particular for this. This is all based off of the MRI, and it's deep inside the thalamus. And this is kind of the preoperative planning that we do with our calculations based off of anatomic landmarks in the skull and in the brain. And then each trajectory and target is also tailored to each individual patient based off of their specific anatomy. We have another video that shows a little bit about this procedure.
What we did today was we used a new treatment with focused ultrasound to non-invasively treat my patient who had Parkinson's disease. The procedural technique involves placing a frame around the person's head. So imagine a metal ring like a halo, and that attaches to the person's head with some pins after local anesthetic is given. And then that serves as a point of reference and also to hold the head and the brain very perfectly still during the procedure. And the rest of the procedure is conducted in the MRI scanner, and we use a specialized piece of equipment that focuses ultrasonic waves at a particular spot that we choose within the brain. And the anticipation is that we would see at least 60, but up to 90% reduction of the tremor. So we do a lot of testing with the patient. We want to see their tremor, and then we want to make sure we're correctly targeting the area of the brain that's involved. And we can do a couple of test treatments without causing any other permanent side effects. And once we see that we're getting the desired effects with the tremor being reduced, and that we're not seeing any unwanted side effects, then we can go ahead and give what I would call a full dose of energy with the ultrasound waves to that particular area of the brain. Anytime we see such an obvious visible change in the person's neurological function and such a life-changing improvement, I just think that's emotional. So to be able to do something like that that's really safe, and we see, the immediate effects without really any substantial recovery, I think that is kind of amazing.
Let's go back and do a lot. Get that while we're here.
It's easier than anticipated. Actually, I didn't experience anything negative, no severe pain, nothing. I'd say it went 100% like it should have. Advice is to seek out the closest institution that provides this care. And if it's Riverside, then you shouldn't have a problem. Dr. Stalman's a good guy. I would recommend to anybody to have it done, and I'm going to have the left side done as soon as I can.
Patients now are becoming very savvy. They're self-educating. They like the idea of the immediate effects, maybe being able to avoid having something implanted and avoiding a trip to the operating room and the expected recovery from an operation.
Well, that's a brief overview of the MRI-focused ultrasound. But the MRI-focused ultrasound is done over the course of a couple hours in one morning. That was our first patient that we treated at Riverside there with Dr. Salvant. The treatment is done as an outpatient, meaning the patients get to go home the same day. The main difference with this and the deep brain stimulation is that, at least at our institution, we're using a frame on the head. And so that frame is there in place to hold the patient perfectly still, so we can keep our sub-millimeter accuracy during the treatment. Once the frame is in place, we'll head down to the MRI suite with our big team of folks that I think you saw in the video. And we will get the frame fixed to the bed, fill that upside down shower cap full of water, and we begin the treatments initially with aligning our MRI perfectly, which can take us anywhere from about 20 to 30 minutes with some very, very small test doses essentially. And then we give a little bit more substantial test dose, just like we do this intraoperative testing in the operating room with the deep brain stimulator, where we warm the area up enough to start affecting the tremor, however, not enough to cause any permanent effect. And that's one of the things that's great about this lesioning treatment, as opposed to our older fashioned lesioning treatments that we abandoned in the 1970s, in that we can deliver a test dose with the patient awake, as opposed to either having 100% on or 100% off with our burning with a thermoablative treatment. Once we determine that we're not having any side effects from treating this area, and then we're getting good tremor control, we essentially turn up the heat a little bit and deliver a bigger ultrasound treatment, and we get our permanent effect right away with the ultrasound. So it's really amazing, and we get to see such a stark improvement right away. Once we're finished, we remove the frame, and the patient gets to go home within the hour. So it's just a really amazing treatment. You probably noticed in the video that patient had a tremor on both sides, and I guess that does highlight one of the downsides of this treatment, that for right now, we're only able to treat the single side at a time. So whereas his tremor was essentially completely alleviated on the one side, there's not a whole lot with the ultrasound, at least for right now, that we can do about the other side. Yes? Before the other side, I think if it gets approved by the FDA and the research continues as it's been advertised to be going right now, we could potentially talk about doing it in the same setting, or spacing treatments out by a few weeks, depending on what the research shows as far as what's safe. What do we do now? Well, if people have a tremor on both sides, we generally have a serious talk about which treatment is the best. When it comes to the hand, people often have a dominant hand that affects their lifestyle a lot more than the other. So if they are particularly interested, based off of the pros and cons, in doing the focused ultrasound treatment over the deep brain stimulator treatment, a lot of times we'll treat the dominant side. And then later, if it becomes approved, we could certainly talk about treating the non-dominant side. Or if it gets to a point where it becomes just intolerable, we can also talk about doing deep brain stimulation just for the one untreated side. Now, I guess with one caveat, with Parkinson's disease being a progressive disease, sometimes even though what we do that day is permanent, if the disease progresses, sometimes the symptoms progress such that they outgrow, I guess, our treatment, in which I guess you could say that treatment isn't effective forever. With essential tremor, as long as we've been studying this, it's effective indefinitely. And so we've followed people for 5 and 10 years. Well, if the ultrasound, I guess since 2016, so 6 years, it's at least effective for 6 years. I would expect it would be effective indefinitely. And the same thing with deep brain stimulation. The only reason we can't say longer than 6 years is just because it's not been around longer than 6 years. There's kind of final thoughts and summary about all these treatments that we have to offer. The movement disorders are a relatively common neurologic condition that affects mostly older adults. Medications are generally considered to be our first-line treatment, but can lose effectiveness over time or produce unwanted side effects, which is what leads us to consider more invasive treatments like our surgeries. And procedures such as the deep brain stimulation and MRI guided focused ultrasound are safe and well tolerated by all our patients and can provide long-lasting improvement of symptoms, which is why we're very excited to be offering those treatments. I think that's all that we have provided for slides, but certainly we have plenty of time for questions. You got a hand up.
Hello. Does insurance usually cover the MRI guided ultrasound?
Yes. As a newer treatment, sometimes we have to go through special channels to get things approved, and it can be a little bit slower to be approved with 1 or 2 of the insurance companies. It's generally approved across the board for the essential tremor, which was the initial use for it back in 2016. And since getting FDA approval for the treatment of tremor predominant Parkinson's disease, I would say 95% of the insurance companies have gotten on board with it being a standard of care treatment. There is one company that comes to mind that we generally have to get on the phone and speak with somebody higher up to explain what we're doing. But it has been something that's generally approved by insurance. And that is something we have a whole army of folks in our office. If that's something that anybody would be worried about being a holdup for them doing the procedure, that we can assist with. We certainly, at least at Riverside, we pride ourselves on making sure that anybody that needs care, whether they have the funds or not.
Hate to ask another question, but I'll do it anyway. Um, is is there a time when it's better to have the procedures? For example, with many types of medical procedures, you want to get it as soon as possible, as early as possible. But with others, you usually, like with cataracts, you might wait until it progresses a little bit more. With either Parkinson's or essential tremors, when is the best time to have any of these treatments done?
With an essential tremor, really the recommendation is just whenever it gets to the point where you're willing to go through a procedure like this. And so typically people suffer from a tremor for quite some time before they seek any medical attention because it's something that's tolerable. People make small adjustments to their daily routine, holding a cup with two hands, for example, drinking out of a cup with a top on it, securing their hand resting their arm on a piece of paper rather than writing, upside down or on a wall. But when those things start to not be effective in controlling the tremor, people generally seek medical treatment, try the medicines. And of course, if the medicines are effective, there's no need to consider something invasive. But when people get to a point where they've gone through the trouble of seeking medical treatment and trying one or two different medications without significant effect, it's a good time to consider the more invasive procedures. That being said, if you have a tremor that's not controlled with medication, whether you immediately seek treatment with a surgeon within a month, or if you wait 10 years, it really doesn't make an effect on doesn't alter how effective the treatment can be or how long lasting the treatment can be. There are limits on the back end. If you're considering getting treatment in your 70s, I wouldn't wait 20 years. Some of these treatments, especially the deep brain stimulation, we do get a little bit nervous with anesthesia when people are past their mid 80s into their 90s. Not that it can't be done and not that we don't do it quite often, but it does give us pause when we do something really invasive with folks that are over 90 years old. With the Parkinson's disease, similar advice. People generally don't seek any treatment until their symptoms are bothersome and not controlled with small alterations in their day-to-day activities. And then once the medications start to become less effective, we'll often speak with the patient's neurologist and then see them for consultation in clinic. It's the treatment or the deep brain stimulation and the MRI-focused ultrasound, as effective as they are in treating the patient's symptoms, they really don't alter the course of the disease. We know, despite our best efforts, that the disease is progressive and it's going to get worse at some point, hopefully over a long period of time. And so as to whether or not to seek surgical treatment immediately when you realize the medications aren't effective versus waiting a long time, it really is up to the patient. And that's something that we'll often talk about with them in our clinic. Certainly doesn't hurt to consult with a physician like myself or Dr. Salvin that you saw in the video, to at least talk about it. And, sometimes we talk to people and they're just not ready, and that's fine. We never rush people into a treatment. We always wait until they're ready. But the main rate limiting factor with that would be if the Parkinson's disease becomes so severe that people are really immobilized and have trouble with dementia symptoms, our invasive surgeries are less effective, mainly because they're not well tolerated by people that aren't of sound mind. They're not able to participate in our intraoperative testing and to really accurately convey how they're feeling and how effective the treatments are while we're testing them. So that's the main rate limiting step with the Parkinson's. And then of course, it's similar to the essential tremor. When we get into the late 80s, we do worry about these invasive treatments as far as how safe they are with the anesthesia.
What are the concerns about anesthesia for older adults with this procedure?
The main detrimental effects of the anesthesia, especially with people with early dementia and Parkinson's disease, is the medications put people to sleep. They're very, very strong medicines that sedate people. And for sometimes with people with dementia, it can really throw them for a loop with their thinking. Usually just temporarily, 24 to 48 hours or so, but sometimes much longer lasting. Folks that are, even if they are healthy in their older years, they have a little bit less reserve. One, as far as their brain goes, even though they're of sound mind, before we give them medicine, the medications can really throw them for a loop. And they also process the medicines a little bit differently. Even though their kidneys and livers are functioning just fine for day-to-day activities, sometimes the stress and digestion of these medicines make the medicines really slow to exit the system and can make a recovery from this surgery very difficult. And if people are slow to mobilize after surgery, brain surgery, belly surgery, any kind of surgery, we start to worry about things about blood clots, heart attacks, strokes. Just when people are slated for a long recovery, those complication rates, just general complication rates, are increased slightly. Okay. Yeah, thank you very much for having me.